Hello, so I'm planning on conducting a short series of videos in regards to placement, sharing my opinions with you guys and advice and how to make the most of placement and what things to look out for. So I'm going to start with the first placement I did, which was AMU, and it stands for the Acute Medical Unit. And this comprised of ambulatory care and also HDU, which stands for High Dependency Unit. And also everyone in the in-between, patients who were not yet given to different specialities and were kind of in limbo. I spent a majority of my time in ambulatory care. Personally, I learned a lot there and I just really enjoyed the atmosphere. I liked what was coming in through the door, and I personally felt that I could practice all of my exam skills. So many of my procedures were done there. So my competency signing off, bloods, blood cultures, cannulas, loads of different exams like PR exams. There's so much scope for practice in ambulatory care, in particularly for histories. So a lot of things to look out for in ambulatory care are things such as suspected pulmonary embolisms, suspected DVTs, suspected giant cell arteritis, suspected epilepsy. These are really common conditions that come in through the door. I would say where I was placed, probably more than 10 a day. So just being there and taking those histories, even if you're taking them over and over again, it's so helpful because every person has different signs and symptoms, and sometimes the D dimer would come back and it would be low, but the person would have like a bilateral embolus in their lungs. So just really important skills and experience to gain from there. Also, there's so many things you can observe whilst you're in ambulatory care, things that you won't particularly be doing and partaking in. Things such as chest drains. So in my ambulatory care unit, we had morning appointments, elective appointments for patients to come in for chest drain. And it's really interesting because we learn a lot about chest drains, but we don't actually ever get to see it unless you're in placement and you can just knock on the door and go in. So it's really interesting seeing the consistency of the fluids being taken out of the lungs, the color, how long it takes, and how much fluid can really come out of people's lungs. It's amazing. I mean, sometimes it was like a liter, so it's crazy. Other things that you can observe and not necessarily take part in are things such as echoes. So again, we had a specialist who had an office in the ambulatory care unit where he would do his echograms, and it's really interesting because we learn a lot about when to do echoes, what echoes mean and what they show you, but we've never actually seen it be done before. So I learned a lot. I didn't realize that they would be uncomfortable for patients, and some of the time they would actually be quite painful, especially for female patients in terms of their breast tissue. It requires a lot of pressure to be forced onto the patient's chest. So that's also really interesting, alongside reading the report of an echogram. So that's something, if you work in primary care, you will be reading them. So it's really good to get used to them, familiarize yourself with the vocabulary. Pardon. So yeah, what else? Also something that, again, we know a lot about when to do them. We know how to read the results and how to interpret the results, but we haven't been trained how to do it. So it's useful to see and observe lumbar punctures. Now, don't ever do a lumbar puncture whilst you're a student. We're not allowed, but you can be there as a second pair of hands, because whoever is carrying out the lumbar puncture, they will need someone who is not sterile to be holding some of their tube bottles, to be handing them other equipment if they need a change of needles. So it's really good to volunteer yourself to be in the room whilst the clinician is carrying out the lumbar puncture. The intricacy that goes into coordinating where the needle goes in is really fascinating as well. And again, I didn't know what spinal fluid looked like. I didn't know how slow it comes out. It's really interesting. I definitely recommend observing that. And then in the high dependency unit, I learned a lot about CPAP and BiPAP. So those are really important as well. More often than not, way more often than not, doctors and registrars and nurses, anyone in the healthcare professional team, MDT, they're so helpful. So if you show initiative and you ask them questions, they're more than happy to teach you and answer you questions, and sometimes even take you along with more interesting cases and show you more interesting cases, even if it's not under AMU. So it's really good to socialize and build a good rapport, I guess, with your colleagues. And in terms of HDU, these are all really critically ill patients who require constant medical attention. So I was able to see a lot of things, and one of the things I wouldn't have seen anywhere else was an insertion of a central line or a PICC line. So essentially what this is a cannula inserted centrally rather than peripherally, for medical access, sometimes nutritional access, and this is mainly done for critically ill patients. And it was really interesting because the ones I observed, their artery was really difficult to locate even with an ultrasound. So these are all like really interesting things you can take part in and witness. Another thing I did see a lot of was thrombolizing patients, and I realized it wasn't that interesting, the actual thrombolysis itself. However, being in the atmosphere of the MDT and being under time restraints, it really puts you in an emergency situation. Obviously, there are things such as CPR and resus, which is in A&E, but in AMU, this was something that it required quick thinking. Everyone needed to come together, and if you're there, they will involve you. They will ask you to hold the notes, read from the notes. They will involve you somehow because they need all hands on deck. So that's really important as well. Another thing I would definitely recommend is every hospital once a week have grand rounds, which is basically teaching for anyone and everyone who wants to join. And also hospitals will tend to have teaching purely for FY1s and FY2s. Now, as a PA student, it is really helpful if you attend those. They do a lot of great teaching. Sometimes it can be boring, sometimes it's really helpful. And also it gives you an hour lunch. Now, I know that sounds really silly, but as a student, I think they kind of forget and neglect the fact that we're there to learn and we're not actually working there. So it's good to make sure you do take an hour break if you need it and if you want it. So whilst I was in the high dependency unit, HDU, the registrars there, they would take turns. So they would have a rota, obviously, and 1 week they would be on MET calls, which are medical emergency team calls, whereby depending on who's on call, they'll get bleeped and they need to attend the emergency. And it's usually patients who have a GCS score of, I think it's over 6 or over 7. Or is it over 8? To be honest, I don't remember because I don't work in hospital anymore. However, these are really critically ill patients. So obviously you can imagine a high GCS is never a good thing. And so if you spend time with the registrar on call during that day, it will really help encourage your learning. And also, when you do things like that, it makes a registrar aware that you're willing to learn and you're active in your learning. So even during a MET call where everyone is panicking, everyone is just doing everything they can to help the patient, even during those times when the registrar has a second, they will come and ask you, do you have any questions? And they will explain to you what they're doing. And they won't necessarily do that if you're just a student and you're standing there and you're just watching, even though that's a really easy thing to do, because during MET calls and emergencies, everyone's just getting on with what they know what to do and going with protocol. So it's very easy to just be very submissive and just kind of mold into the background. But if you have someone who's willing to tell you every step of the way what they're doing, why they're doing it, to get you involved, take advantage of that. It's very, very useful. What else? Yeah, just make sure you practice a lot of your examinations during AMU. It's a great place and you see a lot of weird and wonderful stuff. I remember a lot of the younger consultants who had time and the energy, I guess, but a lot of older ones as well. I am not stereotyping, this is just from my experience. I remember there was this consultant that every time he was on duty, he would always call me over, always be like, oh, you do an abdo exam and you tell me what you think is going on. Or you do a cardio exam and you tell me what you think is going on. And sometimes they would have aortic stenosis, mitral regurg, tricuspid regurg. In an abdominal exam, they just wouldn't have a pancreas. And they'd have something called a Whipple scar, I think, which is what they used to do a long time ago. They would remove people's pancreas, so they don't really often do that anymore. But I learnt a lot just because he knew I was an active learner. So definitely build rapport with your colleagues, as you will learn a lot more. And I just wanted to finish off this video with a story that really resonated with me. So it was my first day of AMU placement and I was in ambulatory care, and my consultant supervisor told me, Neely and my fellow peers, go pick up a folder, go pick up a patient, don't look at what it is, take them from the waiting room and just basically get on with it. So that's what we would do every day anyway, but this was the first day, right? So I went, I picked a folder, called the patient's name, had a quick glance. Don't do that. Always read what's in the folder and in the patient's notes before you go and collect the patient from the waiting room. Hey ho, I was clearly very nervous. Took the patient, took them into a small bay, into a private area. So just to put it into context, there was an 18-year-old girl with her father. And I took her into the room, closed the curtains, started speaking. Next thing I know, I'm interrupted with the senior nurse. She brings me out of the room. She says, Neely, we've got a safeguarding issue. You need to get the father outside of the room. You need to speak to the patient on her own. And I've been seeing her father pacing up and down the hallways. He looks very agitated, seems very angry. So I want you to have this consultation with the daughter on her own, please. So I'm thinking, okay, it's my first day. I don't know what I'm doing, but I will try. So I went back into the regaining the consultation with the patient. And I just said to the father, I'm so sorry. I might have to examine your daughter's stomach and take certain, I don't even remember what I said, but I was just like, you need to leave. And he seemed okay with it. So it kind of made me feel a bit relieved. Then I started asking a bit more, and I had read the notes outside the room. So a little bit of background. The 18-year-old girl had attempted to commit suicide 5 days before by overdosing on paracetamol. And the nurse was worried about safeguarding issues in case there was any domestic violence, any child abuse, any trauma, anything sinister going on at home, causing the daughter to attempt suicide. So, you know, God help me, started the consultation. I didn't really know if I wanted to be there, but the nurse really, she gave me a lot of confidence and said, you know, maybe you can sympathize with her, get more out of her, because they weren't able to do it before when she was first admitted into hospital. So I tried to gauge what the situation was, and it turned out that actually there was no safeguarding issue, thankfully. And the reason why she had attempted suicide was because her partner, who she had been speaking to over the phone with for months and months, decided he didn't want to carry on that sort of a relationship with her, and it just caused her a lot of distress and a lot of emotional upset that she decided she wanted to take her life, purely in order to gain his attention. Now, this was someone she hadn't met before, and also her parents weren't aware of it either. So her parents were quite strict, and apparently they didn't allow her to have relations with another male. So I was in a situation where the patient didn't want me to expose the confidential information she's just given me. Thankfully, there was no safeguarding issues there. And also she was really remorseful for putting her family through this whole scenario because of what had happened. But anyway, that was a really interesting topic that I had during my first day of AMU. I have so many stories that I would love to share with you guys, but that was the first one, so I just wanted to see if she was okay. And as soon as I found out there was no safeguarding issues, I told the nurse. Everyone was super relieved. They were all waiting for me to come out of the room, because you'll experience safeguarding issues are really difficult and really emotionally difficult and stressful for everyone involved, not only the patients but also the whole MDT as well. But yeah, so if you guys have any questions about AMU placements, let me know. I'm happy to answer them, and I will be uploading another video of another placement shortly.